Addiction and recovery in the LGBTQ community. Did you know that 25% of the LGBTQ community abuses alcohol as compared to 5% or 10% of the general population? And that gay men are 13 times more likely to use crystal meth than heterosexual men. Why are addiction rates so high in this community? Looking for solutions in the LGBTQ community can also be pretty daunting. Battling stigma, mental health issues, even the lack of good role models can be just some of the obstacles a member of this community has to deal with. The good news is that treatment centers are now expected to be more sensitive to these issues. This has opened the door to a more inclusive environment. If you are gay or lesbian, bi or trans, and are struggling to find help with your addiction, or you know someone who is, please join us today on Toronto Speaks Addiction. Welcome to Toronto Speaks Addiction. I'm your host, Dr. Vera Tarman. Tonight we're discussing addiction in the gay and lesbian, bi and trans communities. What types of drug use are specific to this community? Are there unique behaviors that are particularly worrisome? What are some of the treatment obstacles that might stop someone from getting help? Can we change these to be more accommodating? I have the pleasure of welcoming a seasoned clinician in the field, Dr. Jim Cullen. He is a registered social worker who has worked in the LGBTQ community as a mental health and addiction care specialist for over 20 years. We are also joined by Nicki, a prominent trans activist who has had to navigate the treatment world that has not been trans supportive in order to find her own recovery. So welcome, Jim and Nicki. I'd like to start, Jim, with just what are the trends in this community that are particularly unique or different?
Well, I mean, for the last 20 years, we've seen, as you mentioned earlier in the show, these rates of 25, sometimes 30% higher prevalence rates of substance abuse, alcohol, and drugs among the queer or LGBTQ community. Depending on the groups within that, though, it varies as well. So, for example, we might have rates of 25% for gay men, but we have higher rates we see for trans folks. And even then, I would suspect the rates are even higher because the self-reporting sometimes is skewed. People don't report what they actually use.
Right.
So we do see these higher rates, and the common sort of knowledge or theory in the field around this is, you know, living in a world where stigma and bias and the threat of physical violence and being told you're less than all has a role in playing in terms of how some people turn to addiction to self-medicate. And, you know, until these things are eradicated, people often say, oh, well, in Canada you can get married now, as if that was a panacea for everything, and so rates should drop, and it's not. And we still live in the society we still live in, and because of the unique struggles in that community, we do see people turning to drugs and alcohol as a way to cope.
Okay, so it's more got to do with the social circumstances around, the environmental circumstances that have driven the rates up.
Right, and it's the same thing with mental health. Like, there are higher rates of depression and anxiety and other mental health issues among I use the word queer population, among the queer population, not because of them being queer, but because of the society in which we live in. Right. And when you live in a more tolerant society that isn't as oppressive, and there isn't the threat of violence, like there's still the threat of violence. Like every year at Pride, somebody's assaulted. And so, you know, that threat causes other dysfunctions in people's lives, like substance abuse as a way to cope, or depression, anxiety, all those different things.
Is there something that's unique about this community in terms of the drug use, the choice of drugs, the behavior around drugs?
Yeah, and we see patterns and we see trends. For example, we see among lesbians and trans folks more alcohol use than men. However, in men, we will see bi men and gay men more of the harder drug use, particularly crystal meth. And as many people know, crystal meth has become extremely prominent in the community, and it is a treatment-resistant issue that we've been struggling with for a number of times. It also changes geographically. The queer community in Vancouver struggles with it much more than the queer community in Toronto, but it's still fairly pervasive in Toronto as well. Much more pervasive than rates among the straight population, for example.
Okay. Nicki, do you want to add something to that specific thing, different trends, maybe in the trans population or?
Well, I mean, the first thing, just to circle the wagons back a little bit, is that any of the data that's collected that's gender oriented it becomes very difficult to track in the trans community. And so, for example, as Jim was saying about drug use amongst men and trans folk, well, there are some trans folk who also identify as men, and there are trans folk who also identify as women. And so that becomes very, very tricky to actually get the data, tease out the data. I think one of the things that Jim mentioned also is the social climate has a great deal to do with it, and I think also adversity that is faced in a social context. So, right now, you mentioned about it's legal for gay people to get married in Canada. However, at the federal level, there is still no protection for trans people. Yep. So it is still at the federal level legal to fire them merely for being trans, to deny them transportation, housing, education, and employment. These are very, very, very serious issues that put trans people at a disadvantage against the rest of the population. And so understandably, this population turns to other means to actually cope with the business of just trying to get by.
I would imagine too that would be really a reason to not seek treatment, because you have to then declare yourself, and then you have all these potential legal ramifications.
Well, exactly right. I mean, there's the double stigma. I'm personally out and proud as a trans woman, and proud of having long-term recovery. But regrettably, I'm a rare beast. Coming out in these studies that report how many people are actually misusing or abusing drugs and alcohol require, in the case of trans people, double disclosure. Number one, the disclosure that they recognize an issue in themselves, and number two, that they have this gender variance of some kind. And in fact, if you come out as having an addiction problem at work, you may well actually get help. However, if you come out as being trans at work, you may actually get fired. And so getting accurate data is going to be close to impossible.
Okay. Well, can you talk more about, I'm as a clinician in the field, working at one of the treatment centers, we're really struck by the crystal meth epidemic. Yeah. Well, what feels like an epidemic amongst young gay men, and how so difficult. You said treatment resistant. That's a great terminology. Did you want to elaborate on some of that?
Yeah, I mean, we're still struggling with finding out how to treat crystal meth in a way that kind of breaks through. So we have some of the highest relapse rates among meth users. It's very difficult to treat. We're using actually medications now off-label. And so part of the difficulty is, one, finding prescribers that are willing to use medications off-label for the treatment. Two, having people that are ready and wanting the treatment. And three, understanding that it is a long-term type of involvement. And so when we look at meth use and we look at recovery, of course, recovery is a lifelong process and all the things you usually hear about, but the intensive phase for meth treatment is about a year. When you read the literature and you look at what's actually been happening, when I think about even my own practice, working with people that are using meth, it's about a year. And what also complicates this is we're now seeing the psychosis from continued meth use still prevalent a year after last use. And so I have people that come into my practice and say, and they're going for a urine analysis. We know they haven't used. And they'll say things like, Jim, you know, can you please close your computer? I see the light blinking, and I think the drug dealers are watching me through your computer. They haven't used meth in a year. And they're back at work and they're back functioning, but they seem to have this sort of ruminating psychosis that just is below the surface. And then I'll ask something like, are you still taking your Seroquel, which is an antipsychotic, even a low dose? And they'll say, oh no, I don't need that anymore. And then trying to introduce the fact that, well, you might still need it. I mean, but what happens is they feel, well, they haven't touched meth, they're back at work, they're able to function, they're okay. And it's a falsehood. You know, they still need that sort of intensive intervention. And we're finding, or I found as well, that without medication, using off-label, I've not seen anybody yet in my practice that's been successful that we haven't eventually had to use a med.
Particularly crystal meth,
Yes.
or any of them?
Particularly crystal
Yeah,
meth.
yeah. Well, that really coincides with my experience, that's one of the highest relapse rates. I mean, when I see somebody coming in with crystal meth, I always think, oh boy,
Yeah.
this person is in trouble, because we don't have very much support,
Yeah.
really. Like,
And
if
even
they're doing anything
it's
long-term.
and with a lot of the studies you're looking at, some of the hesitation to prescribe is because some of the studies do it from a drug substitution point. So we're actually prescribing a stimulant, and we're using that in a controlled way, much like you would use methadone.
Yes.
But we're using the stimulant in a controlled way.
Yeah, I know that they're doing that in the States, so
Yeah.
that's more acceptable in the States than it is up here.
Yeah, exactly.
So if you don't mind saying, what is your practice like? So like in terms of proportions, like how many, and how did you get, maybe just give a couple of minutes.
Yeah, so
how you got
you know,
into
in my practice, which focuses primarily on the queer community, I see, you know, probably a quarter of trans folks, and half of my practice is men, and another quarter would be lesbians and bi women as well. Okay. And it's still primarily men that seem to be struggling with this. Trans folks, meaning trans women and trans men, are less likely to access treatment for a number of reasons. One is because of barriers, such as treatment centers or places not being open to or accepting of. And the other barrier is because of these other disadvantages, sometimes there's financial disadvantage as well. I'm in private practice, so people have to pay for a session, and a lot of trans folks, because of all the other disadvantages, they're unable to. Like I take a couple of people pro bono just because it's my own ethical thing that I do, but lots of people don't. And so I think those are barriers as well, because I think that in the trans community there's more than a quarter of my practice. Okay. But of gay men of my practice that are coming for addiction, 90% are meth.
Really?
Yeah.
Wow. Okay. Now, I'm just going to shift it over to you, Nicki. Do you want to, what are you willing to share about your story?
Anything that helps. I'd just like to, again, circle back on a number of things that Jim brought up, is that there's a high degree of self-selection, as you've admitted, in your practice. The ability to pay, and a higher degree of sense of agency and, frankly, entitlement. Many of the things you're describing seem, based on my lived experience, and I directly interact with a number of trans people. I always think trans folks sound slightly Lord of the Rings, don't you?
That's very funny.
The real life lived experience.
You may not know this, but Nicki is a comedian.
Well, you would never know it. Dry. Certainly have a dark sense of humor. I mean, the truth of the matter is that you don't survive long as a trans person, period, and you don't survive long unless you develop a dark sense of humor and an ability to roll with the tremendous, the industrial amounts of tragedy that one encounters on a regular basis. The number one consideration for those who are active in their use, who are members of the trans community, is price and availability. And so whatever is cheap, whatever happens to be on hand, that may be crystal meth, but it may be.
You're talking about the drug use, not the recovery, the drug use at this point.
Drug and alcohol use. Yeah, okay. It's about what is available, what is cheap, and sometimes, what is provided to them as an inducement to do business. The reality is that unemployment rates amongst trans women, particularly, is absurd. I mean, it's running at 67%. Suicidal ideation and activation is, again, very, very, very high. So many of these, as bizarre as it may sound, crystal meth almost, and I'm not diminishing this, almost sounds like a first world problem when you deal with the realities of lack of housing, education, and as you rightly say, there's a term, I don't know if you've heard of this, it's called trans broken arm syndrome.
I've not heard of it. Explain that.
Well, it's when a trans person goes to see a doctor and says, well, I have a broken arm, and the doctor says, well, I know nothing about trans issues. I can't possibly help you.
Yes.
The barriers to getting good quality help as the type you provide are massive. That said, for those who do seek recovery, and my exposure has been through 12-step programs, Not by choice, but by expedience. There, to my knowledge, there are no detox centres in Canada, and certainly none in Ontario, that are trained in how to deal with trans people. And so
Right.
I actually went, when I went through the DTs, we were talking about this, the DTs from some of these opiates are awful, and you feel like you're going to die. But when you're coming off alcohol, you actually can't. And I was presented with the choice of going through DTs at home or admitting myself into a hospital and being hospitalized, in this case, as a male. And I chose to
Wow.
detoxify on my own and at my home, and it was a horrific 3 days of, classic, yeah, it was dreadful. And so, indeed, yeah, so detox centers, treatment centers, people with the kind of expertise describing drug therapy was simply not available, and frankly, it's still not available. So, what you're describing sounds very encouraging about drug treatment, but it's simply, not available.
It's availability. And the thing that's frustrating as well is it's actually a great time to work in the mental health and addiction field. We have treatments.
Business is good. There's lots of it.
Yeah. But we have treatments and evidence of multiple types of treatments that have been shown to be effective. The problem is the things that have been shown to be effective we're not providing. And so, classic example, in our province, residential treatment programs traditionally are funded for 21 days. I was working in the system when Mike Harris came along and slashed a week off of the 30-day programs.
Yeah, when it was a 28-day
Right.
program,
Yeah, when it was 28 days. And he based that on American research that was funded by the insurance companies.
Right.
Nobody ever talked about that, though.
Yes.
And so they slashed that week off because people don't need to be in residential programs that long. Well,
And your
people do.
experience is they need it much longer.
My experience, the evidence, people that do research in this,
Yeah.
absolutely. Why do you think in federally funded addiction programs for the Indigenous community, they're 1 to 3 months long? Because the feds know that they screw these people up and we better take care of them. So instead of doing what we do in Ontario through regular programming, the federal government, their programs are longer because they need longer care.
Yeah.
And so when you read the literature on this, and then when you look at what we're actually providing in the system, there's a disconnect. It doesn't match. Like, for example, people often ask me, well, what's better, group therapy or individual therapy? And the answer to that is actually, they're both equally the same, but outcomes shoot up 300% if you combine them.
I see.
And
yeah.
so,
Yeah. Well, just to get to the concept or the ideas about recovery and therapy, I work at a private treatment center, Renaissance, and I also work for Salvation Army, which has not had a great history with the LGBTQ community. But individually, the counselors and the actual homes that I work with have actually been quite open to having trans people come in. So I guess my question is, in the last year or 2 or 3, where there's been so much more public awareness, my impression is that things are actually opening up and changing. But what's your experience in the in the trenches, as it were? I mean, yourself as a
I have to think about that. That's a very difficult question to answer because the death rate appears to be steadying, but it is still the question of, for example, every Pride we have coming up. We have the Trans Day of Remembrance, and as I was saying to Jim earlier, the coincidence of drug and alcohol with the untimely death of trans people is at or near 100%. It's not to say that it's a causal relationship, but the fact is that drugs and alcohol are almost invariably linked with the premature death of trans people. And the upper median age is 47, I think, for a trans woman. So the prognosis is not great. And so it's very difficult to hear people say it's getting better when the evidence that there is A, very little data because it's difficult to collect, and B, my first-hand experience is that people are still dying.
So a member living in the community, you don't actually see much difference at this stage.
There is, to my knowledge, I very rarely do people lift them. Seeking recovery begins with having some degree of hope that you can actually find recovery
I see.
and better life afterwards.
Exactly.
And without that platform of hope, there's no springboard to go on onward.
So they're not even getting to that stage.
It's yeah, they don't get through that first hoop. Yeah, and if they did, where are they going to go to actually get? It seems for those of us who are consumers of healthcare, even in this neck of the wood where people are a little more ahead of the curve, still
Toronto.
every time I go to the doctor, where I don't see my regular GP, I feel like a lab rat where I'm engaging in remedial education,
Yes,
with this
education.
trans broken arm syndrome.
Yes.
And I've taken some trans people to even very good, tried to get them through into a detox center, and basically had to stand there and engage in workshopping the counselors, even as the person is trying to get sober. And in that environment where trust is key, trust and a sense of that the other person understands your point of view, I have not seen, I'm trying to think if I have seen one successful graduate. I can't think of one. I have seen some people. There is some good work going on in peer-to-peer support networks right now in Toronto. That is at least promising, if not, make one burst out into song. But there is.
Yeah.
And to be able to integrate those, like one of the things I'm doing in my practice that was a pilot, and now I do it with every client, is I see people individually for individual therapy, but I let them know that at some point we're going to develop what we call a circle of care team, or a care team. And that will be people that we identify together that are healthy and supportive in their community. Then I bring them all in for a big meeting, usually between 5 to 6 people with the client, and we sit down, and I'm literally coaching them on how to support him or her in the community. Because
right, so it's people that they know, that their own family, their own friends.
Family, friends, because even people that want to help sometimes say stupid things. They don't know what to say, they don't know what to do. They've watched too many episodes of Dr. Phil, and they think what he's doing is the way to approach it. Or they see those stupid shows like Intervention, right? And they think that's what you do. And so I spend at least 3 or 4 sessions with that circle of care team, coaching them on how to help them in the community. Because I see people once a week for an hour. And the people that are on that team see them all the time.
And there's well-meaning physicians like myself who, I mean, I'm sure I say stupid things, maybe not the broken arm syndrome, but without not even knowing. And earlier we were talking about how you had at Sherbourne Health Center the first experience of actually having doctors listen.
It was a great opportunity, and that really was actually well said. A definite step forward in the movement of better health care for trans people, at least in Toronto. Sherbourne Health Centre did an amazing thing, which was get a bunch of trans people. And at the time, there was a question as to whether we even existed. Get us in a room with a bunch of physicians, and instead of and explain, the realities. Back then, they would not prescribe. Back then, the whole gender identity thing was just so messed up. You couldn't get treatment if you were HIV positive. You couldn't get treatment if you had another mental health issue, and you certainly couldn't if you were identified as an addict. So it was problematic. But we sat down with them and said, look, we exist and we deserve health care. And we designed an intake protocol at the Sherbourne Health Centre that is, I think, still being used as a model. But
Wow, that's very interesting. Anything else to add about? I mean, I'm interested in what can we do looking forward to make things more inclusive, helpful.
I think there's an adage that everybody's probably familiar with. It takes a community to raise a child, and I think the same adage applies to recovery. It takes a community to help people recover, and when people don't have that community, or if the community that's out there doesn't fit for them, like lots of people recover and find strength in 12-step programs.
I was just wondering about that. How open is that whole framework?
So absolutely, we have queer-specific 12-step programs in the city, but the issue then becomes, what if 12-step programs doesn't work for you?
I'd like to spin off on that, if I may. That my own experience of LGBT 12-step programs has been almost uniformly positive. Paradoxically, the situation that trans people find themselves in today is very similar to the nascent days of AA back in the 30s, where you were stigmatized, set aside from society. for all its faults, and they are many, 12-step programs are free, broadly available, require that you believe nothing. You don't need any income, which is handy because trans people don't have it. Yeah. And certainly in Toronto, a very vibrant LGBT community. And if you don't find a connection with a found family there, there are enough other meetings that you can at least find some sense that you are not completely isolated.
It's about coaching people on what to expect as well. I find I've had better success talking to people around, we call it working the program, or how to sort of work the 12-step programs to meet their needs, as opposed to just giving a referral and saying go. And so I think that's important. And also, if 12-step isn't for them, looking at other healthy alternatives for peer support.
Well, like what?
So,
tell me. I mean, I'd refer.
So for example, a lot of the stuff I do are things like meetups. So I will work with the client, scan a few meetups, talk about why they want to go to those particular, it might be a recreational meetup, it might be, I have a client right now going to a gaming meetup, but these meetups are like social opportunities.
Okay, yeah, I've seen that.
And then to go check them out to see what are the people like. Are these people that are healthy, or are these people that are putting me at
Jim,
risk?
I just want to stop you. We got about a minute left, and I want to make sure each of you have a bit of time to say something that we might not have said that you want the people to hear. So it can continue on.
No, so just that there are things that we're doing differently now that make me hopeful, and that treatment is the treatment modalities we have actually work if they're applied. It's just getting people there.
Nicki, do you want to take the last 20 minutes, 20 seconds or so?
I'll take 20 minutes for sure, but I'll take 20 seconds. Okay. I think the most important thing is to communicate that there is hope, that recovery can be found, and to try and model good behavior. That's it, is that you're not alone, and there is hope. It's going to take work, but you can recover.
Okay, well, I want to thank both of you for spending time to speak, and as a clinician, I'm really happy to hear that there are other alternatives, especially 12-step, because you're right, not everybody wants that. So that is all the time we have today, and I'd like to give a special thanks to Dr. Jim Cullen and Nicki Ward for helping us understand some of the addiction and recovery issues pertinent to the LGBTQ communities. Perhaps this knowledge may encourage you or someone you know to seek help. Remember, although the system has not been historically kind to the LGBTQ communities, conversations like this one today can make a difference. We are changing attitudes, one clinician and one patient at a time. We are listening. I'm your host, Dr. Vera Tarman, and thanks for watching Toronto Speaks Addiction.